Welcome. Hi, I'm Mikki, and this is Mikkipedia, where I sit down and chat to doctors, professors, athletes, practitioners, and experts in their fields related to health, nutrition, fitness, and well-being. And I'm delighted that you're here. Kia ora everyone, it's Mikki here. You are listening to Mikkipedia, and this week on the podcast I speak to Professor Eamonn Quigley all about irritable bowel syndrome, what we do and don't know about dietary and supplemental treatment strategies to help improve and resolve symptoms associated with it. We also discuss intestinal permeability and quote-unquote leaky gut, and what Professor Quigley does not love about that term, and some issues around the testing and what is reported in the literature for gut-related problems and what these actually tell us, and subsequently how these might inform treatment. And we also talk about the gut microbiome and the importance of probiotics to support it. So it is a bit of a geeky deep dive, but you know what? Professor Eamonn Quigley has done numerous talks to the public on this type of information, so he's really well versed in being able to translate science into practical tips. And I think that if you know anyone that has gut-related issues, if you are a health professional interested in the field, if you yourself have any of these issues, or actually you're just sort of interested in it, I think you'll enjoy this conversation. So, Professor Eamonn Quigley, if you are unfamiliar with him, he's a renowned gastroenterologist and is internationally known for his research on gastrointestinal motility disorders, neurogastroenterology, which is the gut-brain relationship, and the gut microbiome. He has published more than 800 peer-reviewed articles, reviews, editorials, book chapters and case reports. He is past president of the American College of Gastroenterology and the World Gastroenterology Organization. His current responsibilities include, but are not limited to, the David M. Underwood Chair of Medicine and Digestive Disorders, Head of Gastroenterology and Hepatology at Houston Methodist Hospital, and Professor of Medicine at both the Institute of Academic Medicine and Weill Cornell Medical College. I've put a link in the show notes to sort of more bio information to Dr. Eamonn Quigley. And before we kick on into the podcast team, I'd just love to remind you the best way to support us is to hit subscribe on your favourite podcast platform, and if there's room to, leave a 5-star review, because that way the information that you're receiving is made much more available to other people who are just searching the interwebs for podcasts to listen to. Of course, tell a mate as well. You know, word of mouth is one of the other best ways to support us. So please enjoy this conversation that I have with Professor Quigley. Professor Quigley, thank you so much for taking the time to speak to me today all about irritable bowel, IBD, probiotics, a whole host of topics which you are an expert in. And as I understand it, you're a clinician and a researcher. So
Right.
Can we sort of kick off with you just giving us a little bit of a background on your background?
Okay, so as you can probably tell, I'm Irish originally, graduated medical school in Ireland, and then completed training in internal medicine and gastroenterology in Ireland, in Scotland, and in the US. And then held a faculty position for 12 years in the US before going back to Ireland to my alma mater, my medical school in Cork, and then moved to Texas almost 10 years ago. I'm a gastroenterologist. I'm a professor of medicine. I've been actively involved primarily in clinical research in a variety of areas, including irritable bowel syndrome, gut microbiome, and probiotics for several years.
Yeah. And as I came across, well, I've seen your papers before, and then of course I was at the Metagenics Congress a couple of weeks ago, and you were talking on a couple of different topics. And one of the things which, or one of your topics on the leaky gut, I found super interesting, actually, your perspective versus what people who, like clinicians like myself, or just people out there in the general population, might understand as sort of leaky gut. So can we start there potentially? And can you sort of describe, I suppose, what some of the issues are around what we think is leaky gut, but what actually is going on? Because I feel like this is something which a lot of people can obviously misconstrue.
It's a challenging topic. What it all hinges on is this phenomenon of gut permeability. In other words, the ability of the gut to allow certain molecules to get across and to prevent others from doing so. If this didn't happen, we would all starve to death, because obviously nutrients, electrolytes, etc., have to gain access to the body. Otherwise, we couldn't survive. So the gut has developed a very sophisticated system in health for allowing certain molecules to pass and others not to pass. And that's what we call permeability. Now, permeability is different in different parts of the GI tract. For example, the small intestine we would regard as fairly leaky, whereas the colon we would regard as not leaky at all. And of course, that makes sense because it's in the small intestine where we digest most of the molecules that are derived from food, like carbohydrates as simple sugars, proteins as amino acids, fats, etc. So that all makes sense. Now, in its strictest definition, the gut barrier, which is what controls this, is a single cell layer on the surface of the gut wall. But one of the points I made in my talk was that many other factors contribute to this barrier function. It may not be, strictly speaking, the barrier anatomically, but at least in terms of function. And that goes all the way from the mucus layer, which lies on top of the epithelium, to a whole variety of molecules that are produced by the gut that protect it against bacteria, etc. And then to, of course, the immune system, and also a recently described barrier that lies between the blood vessels within the gut wall and the epithelium. So there are a variety of components there which can all contribute in one way or the other to whether a molecule, be it good or bad, gets from the lumen of the gut into the systemic circulation, where it could cause problems.
Yeah.
So that's putting it in a nutshell. Now, where the problems arise is not in animal studies or laboratory studies where you can control everything and you can measure things very carefully, but in human studies. So obviously we can't go removing the gut from humans and putting it in an organ bath and measuring permeability. So we have to rely on somewhat indirect methods. And the methods that are used primarily involve using molecules of different molecular size and measuring then whether they appear in the urine or not. And of course, if the gut is more leaky, you would expect to see molecules of higher molecular size, et cetera, et cetera. And that technology is well described. The problem with that technology is that measures one particular phenomenon. It measures predominantly the movement of water and electrolytes like sodium and potassium, sodium and chloride particularly, and simple sugars between cells, the so-called paracellular pathway. And that's fine. Unfortunately, what it probably does not measure is whether bacteria and large molecules get through there, because they're just too big to get through there. And what the criticism I have, or the concern I have, is that people take results from these sugar tests and they extrapolate them to mean that everything can get across the gut wall. That might be true, because there might be, if there's damage to the paracellular pathway, there might be damage to other pathways, but you're not actually measuring that directly. That's my concern. So in other words, we're going from one observation and applying it to things that may not be relevant to it.
Okay. And there are a number of these commercially available stool tests and urine tests which measure metabolites of, or potentially measure, or say they measure metabolites of products related to our neurotransmitters, but also our ability to digest those carbohydrates, proteins, and fats. From your obvious kind of expert position, is it possible for these tests to determine, well, one, that's what we're seeing in the urine, and then two, that actually indicates that we've got a leaky gut or this impermeability? Or is that a bit of a leap as well?
Well, I think, for example, the lactulose mannitol ratio, which is very commonly used, that's a valid test.
Yeah.
It's a good test. And there are other sucralose, there are other sugar molecules can be employed. And they are valid tests of this paracellular pathway. Which you cannot say because you've got an abnormal lactulose mannitol or sucralose or test, that therefore bacteria are getting into the liver. Now that's where I have the problem, is jumping from that observation, which is absolutely well validated, been studied for years, it's a valid test, and then saying that this is the cause of the person's liver disease. That's the problem that I have, because that's a leap of faith.
Yeah.
It might be true, but you have to prove it directly. And one of the major challenges in human studies is the availability of accurate tests for the arrival of bacteria or bacterial products into the circulation, the phenomenon that we refer to as translocation.
Yeah.
That's very, very well measured in animal models. Because in animal models, you can open the animal's abdomen, you can remove lymph nodes, you can remove the spleen, you can take biopsies in the liver, you can count the number of bacteria they're getting through, and you make an accurate assessment. Of course, you can't do that in humans, except in occasional circumstances where you're doing surgery for some other reason, for example. But so it's been much more difficult to measure bacterial translocation in man. We've no doubt that it occurs, but what we don't know is to what extent it occurs and what its clinical significance is. Because a lot of bacteria get through and, of course, are mopped up in the liver and don't get into the external circulation. There's a lot of exciting possibilities here, but I think we shouldn't get ahead of ourselves.
Yeah, no, that makes perfect sense. And then if we're thinking about tests related to the gut that might tell us a little bit about what's going on or give some sort of clinical indication, like you mentioned, that people take a leap of faith with the lactulose mannitol test. How else could we measure what's actually going on if someone experiences gut-related issues? Like what tests would be valid?
There are some very good tests available. For example, measuring calprotectin or lactoferrin in stool is a very sensitive indicator of inflammation anywhere in the gut. And that's one that we commonly use to detect activity in, say, in ulcerative colitis or Crohn's disease. Alpha-1 antitrypsin can also be measured in the stool, and that does provide some measure of whether there's severe change in permeability to the extent that you're actually losing protein from the gut. Again, it's not. I actually did some work on that years ago. It's not a terribly sensitive and accurate test, but it will give you a reasonable idea as to what is going on. And of course, there are other markers of inflammation, like the C-reactive protein level or the erythrocyte sedimentation rate, which may also be helpful. And then, there are a whole variety of tests to assess for absorption or malabsorption, which may also be very valuable.
Yeah. And what nutrient status or are there any nutrients which you often see are related to gut issues? So if someone is low in a particular nutrient, does that give you any insight into that malabsorption rate? So what's commonly seen?
Absolutely. That's a great question. So, for example, if I see somebody who's deficient in folic acid and low in iron, I begin to think of disease of the upper small intestine. Celiac disease would be a classic example.
Yeah.
On the other hand, if I see a patient who's got B12 deficiency and they do not have pernicious anemia, you begin to think of disease in the lower small intestine, because that's where B12 is taken up. And you see that, for example, in patients with Crohn's disease, patients who've had surgeries in that area, and of course, you may see it in patients with small intestinal bacterial overgrowth because the bacteria actually utilize the B12. So there's some examples of hints to you that, gee, if I'm seeing low folate and low iron, I should be thinking of proximal upper small intestinal disease. If I'm seeing low B12 and perhaps a lot of loss of bile acids into the stool, you should begin to think of lower small intestinal disease.
Yeah. Okay. And is this something that you think general practitioners are sort of across, or is it something that someone might get from a specialist like you who actually works in gastroenterology and related fields?
That's a great question. In fact, as far as I know, in the UK right now, family doctors are encouraged to use calprotectin as a screening test for patients for inflammatory bowel disease.
Yeah, nice.
Because it's of its sensitivity and specificity. Now, there are some arguments about the cutoff value, but that's a small issue. But it is an important issue, and so some of these are being used in general practice to screen for diseases like inflammatory bowel disease.
Nice, Professor Quigley. Can we pivot, or just switch topics to talk about IBS, or irritable bowel syndrome, because this is something which feels like I see a lot of clients, and they're like, my doctor's told me I have IBS, and now I have to sort of figure out stuff from my diet as to how to help. But it's almost, am I right in thinking it's a condition that's diagnosed almost from exclusion criteria than anything else?
Yeah, that's a crucial question. Unfortunately, that's often the way it's diagnosed. One of the things I was trying to advocate, or I do try to advocate, is to take a more positive approach.
Yeah.
And in fact, there are criteria, clinical criteria, which have been developed over the years by the Rome Foundation, which should allow you to make a pretty confident diagnosis of irritable bowel syndrome, as long as at the same time you look out for signs of other diseases, like inflammatory bowel disease, like celiac disease, like cancer, etc. And that you can usually detect with, if you maintain a fair degree of suspicion in the right circumstance. So I would encourage a more positive approach to the diagnosis of irritable bowel syndrome. And that's important because I've seen this in my own, unfortunately, I've been around a long time. And one of the nice things I've seen over the years is we've moved from a state where if you said to a patient that they had irritable bowel syndrome, they'd walk out of the office because they felt that you were telling them that it was all in their imagination.
Yeah.
To a situation now where people would say to me, well, Doc, I think I've got irritable bowel syndrome and I know what that means, but I'd like to talk to you about it and just get some reassurance that that is actually the diagnosis. So it's been a sea change, thanks to, I think, a lot of discussion in media, etc., about irritable bowel syndrome, the fact that it is a real entity, the fact that it has consequences, and the fact that we can, in many instances, we can do something about it.
Yeah, nice. And so if we were to define it, what actually is it? So
irritable, like the simplest way I regard irritable bowel syndrome, it's a syndrome where abdominal pain or discomfort in some way or other is linked to bowel function. So, for example, you could have somebody who has irritable bowel syndrome who feels better when they have a bowel movement, or a person with irritable bowel syndrome who gets worse pain when they need to have a bowel movement, or when they have a bowel movement and the irritable bowel syndrome, it leads to diarrhea, or they may have as you know, some people may have constipation, some people may have diarrhea. Another symptom that's very common in irritable bowel syndrome is bloating and distension. They're not included in the main definition, largely because of issues with translation into non-English languages, but I think they're an essential component. So it would be pain linked to bowel action plus bloating and distension.
Yeah. And is there a time period with which is part of that diagnostic criteria?
Yes, no, there are several caveats in there. So they should have symptoms at least once a week, and the symptoms should have been going on for at least 3 months, and should not have developed less than 6 months ago. So that's very important, because otherwise you may make big mistakes, because say somebody who developed irritable bowel symptoms last week, they could actually have an obstruction from colon cancer.
Yes.
So it's very important that you take those time scales into account when you're making the diagnosis. So, we always teach our students and our trainees that, be wary of the sudden onset of irritable bowel syndrome. That's a warning that there may be something else going on.
Yeah. Having said that, do gut issues, yes, you mentioned that sort of sudden onset, but can we develop intolerances or sensitivities as we age or over time? So for example, I have clients who come to me and they're like, I used to feel fine when I had bread, but now I'm constantly bloating, or I feel like now I'm getting bloated. Is that a common thing? Do things change over time?
So this is a fascinating issue. There's a beautiful paper beautiful, very elegant study from a group in Belgium, which is recently published in Nature, actually, is to say that a paper on irritable bowel syndrome appeared in Nature is a major thing in itself. But what they were looking at there was a subsection of individuals with irritable bowel syndrome who have developed it quite suddenly, and usually in the context of some sort of enteric infection. It could be Salmonella, Campylobacter, etc., etc.
Yes.
So-called post-infection irritable bowel syndrome. And what they showed very elegantly is that in these individuals, or at least in some of them, when that happens, they lose their tolerance to certain dietary antigens. So before that, they could tolerate a full diet. But after this event, they now become sensitized to certain foods which previously they tolerated. And when they're exposed to that food now, they develop a local allergic reaction, if you like, which leads to the activation of mast cells, the release of mast cell proteases, which then activate primary sensory afferents, which lead to hypersensitivity and the symptoms that we recognize as irritable bowel syndrome. Now, that's just one study, but I think it's a fascinating example which can explain how somebody, for 40 years of their life was perfectly well, then something happens and now they've got IBS symptoms and they can't tolerate certain foods.
Absolutely. And I guess it's that exposure to some other stressor that created the issue an issue in the first place, but
yes.
Then so it exacerbates our response to those dietary antigens.
And you've actually touched there on a central tenet, if you like, of irritable bowel syndrome.
Yeah.
I very much regard irritable bowel syndrome as a disease of the gut-brain axis. That's fundamental. And then feeding into that are a variety of triggers: food, stress, infection, menstrual cycle in females, etc. So there are a whole variety of things which feed into that, which can be different in different individuals and which can trigger symptoms on the basis of this interaction between the gut-brain axis. But I think that's a fundamental part of it. And we're learning more about these triggers. We're learning that the microbiome, for example, may be relevant. I just mentioned the role of infection. We've learned a lot about food as a trigger recently, a whole variety of foods. And we're also beginning to understand more about how these may interact with the immune system and lead to and I presented some of that data at the meeting in the Gold Coast, can lead to the release of inflammatory markers, which can in turn provoke a local inflammatory response, which may actually spill over even into the systemic circulation.
Yeah, interesting. And so with the gut-brain axis then, so are you saying that what happens in the, or how we perceive stress can sort of exacerbate or change how we digest food and the sort of implications, etc.?
Absolutely. And there are examples of this going back for decades, of a variety of, if you like, experiments in humans showing how profoundly you can affect their physiology through exposure to stress, either acute stress or chronic stress. I always remember a study done by unfortunately a now late colleague of mine in London, where they got their volunteers to try to park cars in rush hour in London. Which was, if you like, an acute and chronic stress. You can imagine what that was like doing. And at the same time, they were measuring their motility and showing how severely disrupted their bowel motility was. And in patients with irritable bowel syndrome, it was even more disrupted. So they were even more sensitive to these stresses. So there was a time, when I was kind of early in research, when there was a lot of work being done on stress, a whole variety of well-validated models of stress, and showing how they disrupted motility, secretion, etc. Everything you could think of: gastric emptying, colon transit, all of these things were affected by stress, and to a greater extent in patients with irritable bowel syndrome, as if their clock had been wound up to be much more sensitive to stress.
Yes, so interesting. Professor Quigley, what are there people who are more at risk of IBS than others in terms of, so what are general patterns in the population that you see?
Now, this has been really given a lot more credence recently with the publication of a very large international survey, which I was privileged to be a part of, which for the first time attempted to provide a global picture of IBS. Now, it's not complete. Not every country in the world was involved for logistical reasons, but they were representative countries from all continents. Less representation from Africa than we would have liked, but still there was representation. And what it showed clearly is that females are twice as likely to develop IBS than males, that IBS is much more common in younger people, in, say, up to the age of 40, and less common in those who are over 65 or over 60. So there are two very important risk factors which seem to be universal. There was a debate about whether there were some countries where it was actually more common in males, but that turned out to be that males had more access to healthcare than females, which is reflected inequities in society rather than actual changes in prevalence, or differences in prevalence, I should say. And then the other risk factors that have been identified, I mentioned one, which was this infection. About 10% of individuals who get an infection, as I said, was Campylobacter, Salmonella, et cetera, they will go on to develop irritable bowel syndrome and will have it for many years. It's much more likely to occur with a bacterial or protozoal infection than it is with a virus infection, which is interesting, because virus infections tend to be shorter in duration and tend to evoke less of an inflammatory response, which may be important. The other very important cofactor which came up from these post-infection studies was that, who are individuals, if 10 people got Campylobacter, and this has been shown because there have been big outbreaks of food poisoning. So, let's say 100 people get food poisoning, 10 of them are going to develop IBS. Well, what are the features of those 10? They're more likely to be female, they're more likely to have had a more severe infection, and they're much more likely at that time to have had depression, anxiety, or stressful life events. So here again, we see this interaction between the brain and the gut. I'm not saying that everybody who's got IBS is depressed or anxious, but if you have depression or anxiety and you're at risk for IBS and you're exposed to a risk factor, you're much more likely to get it and more likely to have severe symptoms.
Okay, interesting. What is the fact that you're female? Is it some sort of interaction with estrogen, or, I mean, that's the first thing that comes to mind. What explanatory factors do we know sort of describe that?
I have to admit that we don't know it, and this is an underexplored area. There are differences that have been shown in the way the brain perceives the gut between males and females. That may be part of the explanation. And there, of course, are hormonal factors which may kick in. But I don't think we have a complete answer on that. It's obviously a very important question.
Yeah. Okay. And is the same set of age, like why younger people are more likely to experience it than older people?
Yes, that also is not. There are some physiological changes that occur with aging in terms of motility and etc., which might explain it. But we don't know the answer for that either. But it is very striking that if you look at that data from the international survey, the highest incidence is like the 20 to 40 group. It's a little bit. It falls off a little bit lower in the 40 to 60, but it really falls off in the over 60 group.
So interesting. And as you say, there's just a lot of other areas, or more sort of areas that can be explored, I suppose, moving forward with regards to clearly understanding that. Professor Quigley, the low FODMAP diet, as a clinician, this is one that I use almost all of the time when I speak to people about gut-related or IBS type issues. Can you sort of describe to the listeners what that is and why it is, and actually how successful is it in resolving IBS?
So the low FODMAP diet arose from the concept that we as humans have a limited capacity to digest certain carbohydrates in particular. In other words, we have a certain capacity, and above that we can't digest them, so they end up going to the colon, where they're digested with bacteria who are delighted to get them. And in metabolizing these molecules, they produce short-chain fatty acids and they produce gas, which of course leads to IBS-type symptoms. So that's the hypothesis. And the group in Adelaide, or not Adelaide, but in Melbourne, who really pioneered this, came up with these particular these foods, the FODMAPs, which they found were particularly likely to cause symptoms in this patient population. And since then, there have been numerous clinical trials which have validated their hypothesis. So that's the general concept. And the idea is that by putting people on a low FODMAP diet and eliminating these particular foods, then you can minimize symptoms. And that actually does happen. Now, how effective is it? In the initial study suggested that it is about 70% plus effective. I think more recently would suggest that it's about 50% effective, which is pretty good in a disorder where, previously we didn't have very effective treatment. So it's become a very important part of the evaluation, of the management of irritable bowel syndrome, and it's quite widely applied everywhere now.
You do have a paper that discusses some sort of implications of long-term low FODMAP diets. And so what is some of the issues or the considerations around that, Professor?
Okay, so the low FODMAP diet is quite restrictive. But the idea is that if you do it properly under dietitian control, you shouldn't maintain a full low FODMAP diet indefinitely. You should actually gradually reintroduce. There's a so-called reintroduction phase and then like a stabilization phase. So you should gradually reintroduce things and broaden your diet with time. The problems with the continued low FODMAP diet would be other nutritional consequences, because a lot of the things that you're eliminating would be regarded as quote-unquote healthy foods. The second thing is that, and this has been a fairly consistent observation, is that low FODMAP diet eliminates a lot of the nutrients that form the basis for the diet of our bacteria, in particular bifidobacteria. So they tend to decrease. So that's an issue. The third issue, which is important, is that very important in using any diet in IBS, is that we now know that there is a higher prevalence of eating disorders among patients with IBS, and that by imposing very strict diets, you may reinforce abnormal eating patterns and perhaps exacerbate them. So that's another thing to be looking out for.
Yeah. Oh, that's interesting. As I sort of understand it, with that sort of food reintroduction, like that, when I see a client and they've got severe IBS or, bad gut issues, and then we put them on the FODMAP approach, I generally start with that broad, hey, try to lower overall load. But
exactly.
Then you'll know soon enough what foods are actually triggering your symptoms and then sort of reintroduce slowly. Are there foods, or should people expect to be able to include all of these foods sort of if they do it properly? Or for some people, are they always going to react to a certain food group? Like, how does that look?
Yes, I think that's absolutely true. I think this is going to be very individualized, but people are going to find out that there are certain foods that are complete no-nos for them.
Mm.
And, some of those that tend to crop up quite commonly, I'd say the fructans, which of course is very common in wheat. Onions and garlic also tend to crop up very frequently. But, it's going to be different for everybody. But you'll find that out in the reintroduction phase. And that's the part which is usually forgotten. That, people read about the low FODMAP diet or get a handout or whatever, and they just start on it and there's no supervision. And then that's when people get into trouble.
Yeah, for sure. And you mentioned that a lot of these foods removed are ones which might feed our bifidobacterium. So would we, clinically speaking, suggest that they take a probiotic alongside a low FODMAP diet? Or for some, is that not a good idea? Is there a recommendation around that?
Well, no, there actually is data. There's a nice study from a group in London showing that if you do that, if you give a probiotic, you actually can restore the bifidobacterial numbers, and that will have no effect on the clinical response. In other words, it won't impair the clinical response in any way. There have also been studies done where people compare the low FODMAP diet to a prebiotic, which is very interesting because a prebiotic, strictly speaking, you'd expect to have the opposite effect. And they actually show that a prebiotic, I think it was an oligofructose, I can't remember now precisely, was just as beneficial as the low FODMAP diet, but did not impair the bifidobacterial population.
Interesting. Would you expect that to be an individual response, or a more general sort of finding for a lot of people with these gut issues?
There is actually some data to suggest that individual responses might be predicted by your baseline microbiome. So that's a very interesting concept. It's not been applied very generally, but I think that's very interesting. You might be able to select those who might respond to a low FODMAP diet. Now, that's not been done for prebiotics or probiotics, but certainly you might you might be able to predict who's going to respond to a low FODMAP diet by studying their baseline microbiome and thereby select people who are responders and not expose them to a diet that's not going to work for them.
Yeah, okay. No, that makes sense. Professor Quigley, on probiotics, it is such a minefield out there when you go to a pharmacy and even the supermarket, and you can see on the shelves all of these different probiotic capsules. Is it a strain that we are looking for? Is it a group we are looking for? So what should we be looking for if we're thinking specifically IBS and the potential for a probiotic to help us?
Okay. So you've asked probably about 10 very difficult questions there in all in one fell swoop. So let's start with the basics. So when you're buying a probiotic, you must be sure there's a probiotic. And the definition of probiotic still refers to live microorganisms, which when taken in adequate amount, confer a health benefit to the host. So let's parse that a little bit. So it should be live. That means that the producer, the seller, should be able to guarantee that there are live organisms at a reasonable count for the shelf life of that particular product. And I can tell you that most products don't do that. So even at first base, they can't tell you that. Secondly, they should be able to tell you exactly what's in there and what isn't in there. And for me, nowadays, that means that the probiotic or probiotic cocktail, if there is a cocktail, should be characterized at genome level. So you know exactly what the organism is and that it's not anything else. That it's not there was a few years ago, somebody took a look at a load of probiotics off the shelf somewhere in the US and found that some of them even contain pathogens. So quality control is an enormous issue here. So there are some basics in quality control that I would insist on. First of all, characterization of your strains at genome level so that you can reproducibly check every batch. Secondly, viability at the level that's thought to be effective for the shelf life of the particular strain. And thirdly, preclinical studies demonstrating what are the range of properties of mechanisms of action of that probiotic. Is it anti-inflammatory? Does it produce gas? Does it interact with your immune system? Does it have metabolic effects? So there should be a very thorough characterization of the probiotic and also a thorough characterization of its viability and of its safety before it ever arrives on the shelf. And I will venture to guess that 90% of so-called probiotic products that are out there do not meet those basic criteria. So that's the first thing. So let's assume that we have a well-characterized probiotic that is viable, which has been studied and demonstrated to have certain effects, and which has been shown to be safe. Let's make those assumptions. So what else do we need to show? We need to show that it actually is effective. And that means clinical studies in the disease that you're interested in, which in this case is irritable bowel syndrome. Now, the good thing is there actually are quite a few studies of probiotics in irritable bowel syndrome, and there are studies which show that some are effective and some are not. But there are reviews out there, systematic reviews, meta-analysis, etc., which can guide you in terms of selecting probiotics for irritable bowel syndrome.
And are we looking at particular strains, or are we looking at groups?
That's a very important. There are some probiotic effects which may apply to a whole species, but there are certainly others that are very strain specific. And in general, the data would suggest that bifidobacteria, that's the species. Bifidobacteria in general seem to be more effective in IBS, and some bifidobacteria are more effective than others. That's just a general observation. But unfortunately, we don't have many head-to-head studies, where they've compared different strains and species at different doses, etc. We have very few of those studies.
Okay, so it might be a trial and error within that for someone to sort of take something and notice an effect or not, and then depending on that, either continue to take or switch out and try another.
So what I would say to the consumer is, first of all, try to have as much confidence as you can in the quality of the product that you're buying, for the criteria that I mentioned: the viability, the characterization, et cetera, the safety. And then try and take a product which has some evidence that is effective in irritable bowel syndrome, such as certain bifidobacteria. That's I think as far as you can go at the moment. Now there are ones that I prefer, which may or may not be available for you in New Zealand, but there are some that I believe have good quality clinical trials which support their use in irritable bowel syndrome, and they can be taken. And if you're not seeing a benefit within 4 weeks, then, as you say, try something else.
Okay, and is that the one that you presented at the Congress, the bifidum, I'm going to get the number wrong,
3562, longer, the species substitutes is longer than 35624, exactly. That's one that I worked with for many years. And of course, obviously, I've got a particular bias towards that, but that's one that we feel is effective.
Yeah, well, it's funny you say you have a bias, because if you, a clinician and research expert in the field, has a bias towards something, then that is likely going to influence my decision to look out for it, because you are the expert in that. So yeah. Professor Quigley, now outside of the FODMAP diet, psyllium husk is another sort of nutritional therapy that is often used for both constipation and diarrhea dominant IBS. Well, actually, how does that help both of these seemingly contradictory conditions?
So, and that's often tricky to explain to patients because they can't say it can't work for both, surely, but it does. So how it works basically is very simple, is that, and we actually studied this several years ago, is that psyllium is a water attractant. So in somebody who's got diarrhea, it will tend to take up some of that extra fluid, if you like, and make the stool a little bit bulkier. In the person with constipation, it again attracts fluid, makes the stool a little bit softer and easier to pass. So, and it has other effects as well, but that would be putting it simply.
Yeah.
But it's largely through its ability. The other thing, of course, is with psyllium, like, because it acts as a prebiotic as well, it's going to increase your bacteria and therefore increase the bacterial load, which in turn may help to make the stool easier to pass.
Yeah. Okay. And what is the recommendation around using psyllium as a therapy for IBS?
I use it a lot. I probably use it more in IBS for constipation. We use it as a first-line therapy in constipation. There are a variety of preparations of psyllium out there, which tend to be quite palatable, and we don't seem to run into problems with patient acceptance or tolerance of them. So I certainly do recommend it.
Yeah. And I'm pretty sure I saw a study that used 7 grams of psyllium a day and 700 mils of water or something like that. So do we have to be particular about the number of times we use it in a day, or is it with every meal?
Yeah, it depends on what preparation you use. Some of them you do need to take water with. Sometimes some it's not so particular. I wouldn't go overboard with it, certainly, but I tend to tell people to take it once a day and maybe take 1 or 2 doses. The preparations we use here tend to be, they use scoops rather than I know there are preparations out there which are based on tablets or other forms, but the ones we use tend to be in the sachet form.
Yeah.
So that's fairly easy to regulate.
Yeah, for sure. And then if someone does have IBS and they are looking at a FODMAP diet, or they're looking at using psyllium husk, or maybe doing a bit of both, how long should they expect to be on this regime for before they look at progressing off? Or is, once you have to take psyllium for constipation, you just have to continue to take it? Like, what is the...
You mean, how long do you wait until you decide that it's working or not? Or how long do you keep it going?
Yeah, how long do you keep it going? Like, because psyllium works for a lot of people that I talk to anyway, but then do they have to continue to take it until the end of their days, or?
Yeah. I think what's very important there is the history. So is this constipation which did just happen because they traveled, or is something that's been going on for years? If it's been going on for years, my prediction is that they're going to need it for a long time.
Yeah.
So I think the history leading up to their encounter with you is going to be very important in terms of predicting how long they're going to need to use it.
Okay, no, that makes sense. And what other therapy is out there outside of psyllium and a lower FODMAP sort of diet for people with IBS? So is there anything else that they can look at to help resolve some of their symptoms?
Well, there are a whole variety of approaches which are out there, which I suppose reflects that we don't have great treatments. There are a whole variety of prescription medications to treat either diarrhea or constipation.
Yeah.
There are a variety of agents to treat pain, like antispasmodics. And then there are what you might call a whole variety of mind-body interventions, like hypnotherapy, cognitive behavior therapy, yoga, etc., which have also been shown to be effective. And I think they're very interesting and are now supported by high-quality randomized controlled trials and undergoing quite a renaissance in the management of irritable bowel syndrome. And some of them are available now through apps.
Yeah. Oh, no, that makes perfect sense, right? Because if a stressful situation exacerbates your gut-related issues,
right,
learning how to manage your stress will or should help sort of resolve some of that stuff.
Right.
Yeah,
exactly.
Nice. Dr. Quigley, is there, what are you excited about in this field? Like, what's new and fresh, and what are you working on right now?
So what I think is new and exciting is the openness of people to look at a variety of possibilities. And for example, I'm now struck again at this late hour of my life at how important the brain aspects of this are. And certainly new imaging techniques have taught us that brain appreciation of gut events is altered in IBS. And I think we need to learn a lot more about that. And I think the more we understand that IBS is a heterogeneous disorder, and the more we're prepared to accept that different triggers, different factors are relevant to different people, then I think we'll begin to make progress. I'm interested in diet and how it interacts with the microbiome. I'm interested in the microbiome and how it interacts with not just the immune system, but even with the brain. I think that's a very interesting phenomenon. And I think we're going to hear a lot more about that in the years to come.
That's nice. Awesome. Professor Quigley, thank you so much for your time today. I really appreciate it. And I will link to your research publications, the page with which you've got such a history of work or body of work in this field, which interested people can go and search out and enjoy the rest of your evening.
Thank you very much. Thank you.
All right, team. Hopefully you enjoyed that. I certainly enjoyed talking to him. And as I said, links to Dr. Quigley can be found in the show notes. Next week on the podcast, I have a good old chat to Dr. Michael Twyman, who is a quantum physician and is all into functional medicine and tactics and tools to help support your cardiovascular health. You will absolutely love this, because I certainly did. Until then, though, you can catch me over on Facebook at Mikki Williden Nutrition, over on Instagram and Twitter at Mikki Williden, or over on my website, mikkywilliden.com, where you can book a one-on-one consult with me, sign up to one of my meal plans, or join my recipe portal access, where for $12 a month, you get access to my recipe portal. You get to connect one-on-one with me via our online messaging system. You become part of my Real Food community, where we do regular Facebook Lives and updates, and you get my weekly email. I mean, it's all just pretty awesome, to be honest, but maybe I'm just a bit biased. Anyway, you guys have a great week. See you next week.